Hi, everyone. My name is Melinda Telli, and I'm happy to be here today to cover this topic, what's new in breast cancer treatment. These are my disclosures. So fortunately, there has been a lot that's new in breast cancer this year, and it is hard to pick out what to include, but these are the topics I'm going to cover today. First, PARP inhibitors in early stage BRCA-associated breast cancer. We'll move next to updates in immunotherapy for triple-negative breast cancer. And finally, finish up with a discussion of some of the new antibody-drug conjugates for advanced breast cancers of various types. So we can start with the PARP inhibitors. So at the American Society of Clinical Oncology meeting this summer in June, we saw the top line results from this incredibly important study called OlympiA. So we have had PARP inhibitors approved for the treatment of breast cancer associated with the BRCA mutation in the advanced or stage 4 metastatic setting. And OlympiA was the large study to look at the role of a PARP inhibitor, in this case, olaparib, in high-risk early stage HER2-negative breast cancer that was associated with a BRCA1 or BRCA2 mutation. So we were really looking forward to seeing this data. This is the schema of the trial, and it's pretty complicated, so I'll try to summarize. But this was a study. It enrolled 1,836 patients, and this was conducted worldwide. It was a large multi-center international study. Patients had to have a germline mutation in BRCA1 or BRCA2 and had to have HER2-negative breast cancer that was either stage 2 or stage 3, or if the patient received preoperative chemotherapy, neoadjuvant chemotherapy, they were eligible if they did not achieve a complete response. So there's a lot of details here exactly how they selected the patients for this study. But I think the main takeaway is that these are a high-risk group of patients, both who had triple-negative breast cancer, as well as hormone receptor positive HER2-negative breast cancer. And patients were randomized 1-to-1 to receive olaparib 300 milligrams twice a day for 1 year versus a matching placebo twice a day for 1 year. If we look at the patients that were enrolled, you can see that the median age was 42 to 43 years. The majority of patients, over 70%, had a BRCA1 gene mutation, and just over a quarter BRCA2. If we look at the type of breast cancer, the majority of patients had triple-negative breast cancer, over 80%, and the remainder had hormone receptor positive HER2-negative breast cancer. The patients received prior chemotherapy. About half of them received it in the what we call adjuvant setting, so after surgery. And about the other half received their chemotherapy prior to surgery. So this is neoadjuvant. So it was pretty well balanced in that regard. And these are the top line results from the OlympiA study. Very exciting. If we start off in the top left, this is looking at the survival free of any invasive disease, so any type of invasive disease recurrence. And you can see that the patients who received olaparib had superior invasive disease-free survival, the yellow line, compared to the patients who received placebo in blue. And there was a difference at 3 years in the rate of disease-free survival of about 8.6%. And we look at the top right, this is looking at the distant disease-free survival. So survival free of any distant recurrence of their breast cancer, again, favoring olaparib compared to the placebo, with a difference at 3 years of 7.1%. At this point in time, the overall survival down here in the bottom right is not yet mature. It is trending towards olaparib, but further follow-up is needed to show if olaparib can improve overall survival in this setting. But very interestingly, if we look at the type of first disease-free survival events, what we learned in this study was that olaparib helped to reduce distant recurrences, but also local and regional recurrences, so in the breast or in the regional lymph nodes, but also, interestingly, helped to reduce the occurrence of non-breast malignancies. So there were fewer ovarian cancers, fallopian tube cancers, as well as other cancers, suggesting that olaparib may have a preventative benefit for patients with BRCA1 and 2 mutations. So really exciting data. All of this was great to see it. In terms of the adverse events, we were interested in how patients tolerated this therapy. And you can see on the left that there was more nausea and fatigue, primarily with olaparib compared to placebo. Most of these were lower grade events, so not more severe types of side effects. There was also some increase in some blood count lowering, anemia, leukopenia, as well as neutropenia. But we were really interested in one adverse event of special interest in particular, and this was the risk of myelodysplastic syndrome, MDS, or AML, acute myeloid leukemia, because there had been reports in the advanced disease setting that patients who had been previously exposed to PARP inhibitors had higher rates of these bone marrow disorders over time. And so in this curative patient population, we wanted to make sure that these types of side effects, which are very significant, were not being overrepresented. And fortunately, there were only 2 events of this leukemia MDS in patients treated with olaparib and 3 in placebo. And so we really did not see any increase with olaparib. And also looking at secondary new cancers, again, there were fewer new cancers in patients treated with olaparib compared to placebo. So really reassuring data that really helps to make us all feel very comfortable with this approach. And so the take-home messages from OlympiA were that 1 year of adjuvant olaparib in high-risk HER2-negative breast cancer associated with a germline BRCA1 or BRCA2 mutation improves the 3-year rate of invasive disease-free survival, a gain of about 8.6 percentage points. It improves the 3-year distant disease-free survival by about 7%. And we're still waiting for the overall survival data. Again, the patients that were enrolled, it wasn't all comers. These were patients who were felt to be at high risk for relapse with either triple negative or hormone receptor positive HER2 negative breast cancer. And as I discussed, the safety data really looked excellent at this point in follow-up, with no increase in MDS or AML. But certainly we will continue to follow patients for these events as we move forward. And so there are a lot of implications of OlympiA. Certainly, first off, based on these results, we do expect that olaparib will be approved for this indication. But certainly we're going to need to expand our testing for BRCA1 and 2 in early breast cancer to better identify who are the patients who would benefit from this treatment. And certainly that is complicated. We need to change our testing guidelines and overcome things around insurance or payer coverage. But these are all things that I think this important data will prompt. If you look at the right, this is a recent analysis from one of my colleagues, Allison Kurian, looking at newly diagnosed breast cancer patients in Georgia and California over a 4-year period. And this study found that only about a quarter of the patients received genetic testing, some BRCA1 and 2 only, and others multi-gene panels. But it just goes to show that there are a number of patients with newly diagnosed breast cancer who are not getting this testing currently. And so that will be the challenge, to try to have enough capacity to see and test patients as we move forward. At the ASCO annual meeting, there was another study presented. This was a phase 2 trial called NeoTALA. And this was sort of a very different approach, but it looked at giving a PARP inhibitor, in this case, talazoparib, to patients with BRCA1 and 2 mutations who had early HER2-negative breast cancer. And this was given by itself. So it was just monotherapy with talazoparib given prior to surgery. And this is the schema, a very straightforward study. Patients were eligible if they had HER2-negative breast cancer. They had to have a germline BRCA1 or 2 mutation, had to be suitable for neoadjuvant or preoperative therapy, and had to have a tumor that was either lymph node positive, or the tumor in the breast had to be at least 1.5 centimeters, and there had to be no evidence of any distant spread. The plan initially was to enroll 112 patients to receive talazoparib, 1 pill a day at 1 milligram for 6 months. And then surgery would happen. And the primary endpoint was to look at the rate of complete response at the time of that surgery. And if we look at the patients who are enrolled in NeoTALA, again, generally younger, median age was 44.6 years. And if we look at the types of breast cancer, there were in total 61 patients ultimately enrolled. They all had triple negative breast cancer. So I mentioned earlier that the plan had been to enroll 112 patients with both hormone receptor positive, HER2 negative, as well as triple negative breast cancer. But unfortunately, the sponsor of the study decided to stop the trial early. And at that point in time, only 61 patients with triple negative breast cancer had been enrolled. Most of them had a BRCA1 mutation, 78.7%. And this shows the stage breakdown. About a third of them were stage 1, 44% stage 2, 23% roughly stage 3. And these are the main results. So this is showing it in a couple of different ways. This is on the left here by independent central review. And then these are the data looking at the investigator. And there were a couple of different populations, but if we just look at the intent to treat population, all of the patients in green, you can see that these rates really come close to 50%. And that is around the type of complete response rate that we typically see with combination chemotherapy for triple negative breast cancer with a BRCA1 or 2 mutation. And so I think this is really provocative data. It's a small study, phase 2, only again 61 patients. But the hope is that these types of approaches will continue to be studied to see if this could be an option for more patients in the future, a chemotherapy-free treatment regimen. We'll move next to talk a little bit about triple negative breast cancer and all of the great data coming out looking at the PD-1 and PD-L1 immune checkpoint inhibitors. So there has been a lot of attention given to these drugs in the last decade. We are talking here about antibodies generally that target a protein called PD-1 or PD-L1. And PD-1 is called programmed F1. And this is a receptor that is located on T cells. And our T cells are the cells that come in and kill cancer cells when they identify them and recognize them as being potentially harmful. But if the tumor cell or cells around the tumor express this protein called PD-L1. These come together, the PD-1 and PD-L1, and that essentially turns that T cell off. And so the T cell can't come in and attack that cancer cell. So what these drugs try to do is just bind to interfere with the PD-1 and PD-L1 coming together, so that the T cell is then free to go and carry out its effector function. So one of the big studies in triple negative breast cancer is this one. It's called Keynote 355. And this is a study, a phase 3 trial for patients with metastatic triple negative breast cancer who are receiving treatment for their first recurrence. And in this study, patients received pembrolizumab, an anti-PD-1 antibody with chemotherapy, or a placebo with chemotherapy. And the choices for chemotherapy, there were a few of them. Patients could receive paclitaxel, nab-paclitaxel, or the combination of gemcitabine and carboplatin. And patients were continued on treatment until their cancer progressed or until there was unacceptable toxicity. What we saw last year at the American Society of Clinical Oncology meeting was that in this trial, the addition of pembrolizumab, the PD-1 inhibitor, did improve progression-free survival. So the period of time women were alive, free of progression of their cancer, if their tumors were PD-L1 positive at this threshold CPS 10 or higher. And so there was about a 4-month improvement in this progression-free survival. And that led to an accelerated approval by the FDA back in November of last year for PD-L1 positive metastatic triple negative breast cancer. And so we were really waiting to see the longer term follow-up to see whether pembrolizumab, if we add it early, can it help patients ultimately live longer? Can it improve overall survival? And so just this month at the European Society of Medical Oncology meeting, we saw the overall survival update showing that yes, in fact, the addition of pembrolizumab to chemotherapy does improve overall survival. And the difference between the two groups for this group of patients with metastatic triple negative breast cancer, it was about a 7 months on average improvement in overall survival with pembrolizumab. And so this data did help to convert that accelerated approval into a full approval, again, for the first-line treatment of metastatic triple negative breast cancer that's PD-L1 positive. And just as that data was coming out, we were getting more data from this study. So this is another important phase 3 trial called Keynote 522. And this is a study looking at patients with triple negative breast cancer early stage, so stage 2 or stage 3, asking the question whether pembrolizumab could improve outcomes if we add it to standard preoperative chemotherapy. And so patients in this study, again, had stage 2 or 3 triple negative breast cancer. All patients were enrolled, regardless of whether their tumor was PD-L1 positive or negative. They received chemotherapy with carboplatin and paclitaxel, followed by either AC or EC chemotherapy, and were randomized to receive pembrolizumab or a placebo. And then patients went to surgery. After surgery, the pembrolizumab or placebo was continued for an additional 27 weeks. So in total, 1 full year of pembrolizumab or placebo. And this was first presented with data just looking at the rates of pathologic complete response at the time of surgery. And in the first 600 patients in the study, there was an improvement in the rate of complete response at surgery with the addition of pembrolizumab to chemotherapy. But the big question was, again, would it impact the long-term outcome? And so just again, this month at the European Society of Medical Oncology meeting, we saw some updated data from Keynote 522, showing that in fact, the addition of pembrolizumab to chemotherapy did improve event-free survival compared to the patients who received chemotherapy with the placebo. And so overall, there was a 7.7% improvement in event-free survival with pembrolizumab. And so based on this, this did lead to the first approval of an immunotherapy drug for the treatment of early stage breast cancer, particularly stage 2 or stage 3 triple negative breast cancer. This is the data looking at distant progression or distant recurrence-free survival, showing that with pembrolizumab added, patients had fewer distant progression or recurrence events. And certainly the toxicities are very pertinent in, again, a group of patients who have curable breast cancer. And we know with these immune checkpoint inhibitors that target either PD-1 or PD-L1 that we can see some immune-mediated adverse events or side effects. And so this is a figure showing some of these different types of immune-mediated side effects. They're quite different from typical chemotherapy. You can see changes in the thyroid levels, either too low or too high, skin reactions, adrenal insufficiency, lung inflammation, intestinal or liver inflammation. So fortunately, some of those events are uncommon, but certainly we see more of these types of side effects when pembrolizumab is given compared to chemotherapy alone. And so as we start to use this more and more in the early stage setting, we have to be very mindful of these side effects so that patients can get the benefit from the drug, but not be in a position where they are at risk for very severe toxicity. So important to monitor, be aware of the side effects, and promptly treat and discontinue the drug if there are more severe side effects noted. I'm going to just move now into the antibody-drug conjugates, and there's been a lot of activity here with the antibody-drug conjugates in breast cancer. So there have been a couple of drugs getting a lot of attention. The first one is a drug, trastuzumab deruxtecan, or T-DXd. This is an antibody that targets HER2, and it's conjugated to a chemotherapy drug called DXd, which is a topoisomerase inhibitor. And this was evaluated in an early phase study in HER2-positive metastatic breast cancer, heavily pretreated. And there was outstanding activity with this drug in that setting. And it led to the FDA approval back in December of 2019 for HER2-positive metastatic breast cancer. And the other drug, sacituzumab govitecan, this is another antibody-drug conjugate. This antibody recognizes a protein called TROP2 that is present on the surface of many solid tumors, including breast cancer. And it's linked to a chemotherapy similar to the DXd. This is SM38. And this in an early phase study also showed good activity in advanced triple negative breast cancer that was heavily pretreated and led to an accelerated approval back in back in 2020 in April. And so in the last year, we saw this trial come out. This is the ASCENT phase 3 trial, looking at sacituzumab govitecan versus standard chemotherapy for patients with pretreated metastatic triple negative breast cancer. Patients were eligible if they had had 2 or more chemotherapies for advanced triple negative breast cancer. And what we saw in the study is that the sacituzumab govitecan in this setting really outperformed standard chemotherapy There's improved progression-free survival, improved overall survival, as well as response rate. And this led to the full approval of this drug now for metastatic triple-negative breast cancer. In terms of side effects, we do see some blood count lowering with this drug, as well as some intestinal side effects. So there are more chemotherapy-like side effects with this drug, but it is an active agent and is being evaluated in additional studies earlier in the treatment of triple-negative breast cancer. And just at the European Society of Medical Oncology Congress just this month, we saw the first phase 3 results with the T-DXd drug, so the trastuzumab deruxtecan, and it was being compared head-on to TDM1 for patients with HER2-positive metastatic breast cancer. This was the DESTINY-Breast03 trial. And in this study, patients had to have had metastatic HER2-positive breast cancer treated previously with trastuzumab as well as a taxane chemotherapy. And they were randomized 1-to-1 to receive T-DXd or the TDM1 drug, which is currently a standard in the second-line treatment of HER2-positive metastatic breast cancer. And what we saw from the study was that the T-DXd, the trastuzumab deruxtecan, really outperformed what had been our standard, the TDM1. This is showing the progression-free survival data that really strongly favored the T-DXd. You can see with T-DXd, nearly 80% of patients had a response defined as a 30% or greater tumor reduction compared to 34% with TDM1. And 16% of patients with the T-DXd achieved a complete response to treatment. So really active drug. We wanted to focus in on the risk of lung toxicity because T-DXd had been reported to cause up to about a 15% risk of lung inflammation. And in this study, the risk of lung inflammation was 10.5% with T-DXd. Most of these were lower grade. So that was reassuring that we didn't see any of the more severe high-grade events in this trial. So this has certainly led to a change in the standard of care for HER2-positive metastatic breast cancer. And finally, we have seen some recent early data looking at this drug, Datapotamab deruxtecan, showing activity in triple-negative breast cancer. This is, again, one of the TROP2 targeted antibody-drug conjugates. And interestingly, some data that suggests potentially this drug has less toxicity than the sacituzumab govitecan. So there are right now 2 big studies that are being launched to look at this drug in both triple-negative breast cancer in the metastatic setting, as well as hormone receptor positive HER2 negative. And with that, I thank you for your attention. I am happy to answer any questions that you have in the live Q&A coming up next.